1, 2. 1, 2. More live transcript. Okay. Share screen. Let's see. Let's cancel that here. It's over here. It's over here. Display settings, swap. Disable. Share screen. See if we can go to Facebook here. Okay. Well, we are going to begin now. We welcome you to come to join our session today. I appreciate that many, because it's a little bit off our schedule, some may have forgotten or join us later. But the video recording will be done and posted to YouTube later today so that those who missed it can get that, and also so that those who have seen it here can review if there's something that came out that you forgot. And likewise, the digital slides are available for review through the DAPA link that was posted with the announcement. So I'm going to switch screens here, and we will take a look at the slides. Our first case is a from the realm of skin pathology, but last month we talked a lot about GI cases, and I thought that this month we would focus a little bit on some GYN cases and the lower GYN tract in particular. So can you all see my screen with the digital slide?
Yeah, I can see it.
Okay, very good. So low magnification, this was clearly a slightly papillary lesion or slightly polypoid raised lesion. And looking at low magnification, this looks like skin. We can see adnexal structures here, some hair follicles. And the other thing that stands out at low magnification perhaps are these areas of hemorrhage in this sort of slightly raised area. So that's the part that we're going to focus on as we come into higher magnification. And what we see here are somewhat unusual pattern of vascular spaces here immediately beneath the and almost wrapped in the epidermis. So you can see here, these vessels are right adjacent to, with the endothelial cells pressed right up against the lower layer of the epidermis. And then of course there's some extravasation. You see a little bit of vascularity beneath this as well, but not too much. And notice that we don't see any larger vessels. These feeding vessels are very delicate vessels to this lesion. So of course, any lesion where you've got vessels and so forth being made with extravasated red cells and so forth, you're going to be thinking of a hemangioma and so forth. And certainly you could make the diagnosis of, cutaneous hemangioma, and that would be fine. It would be correct to call this a hemangioma. But this is a rather unique form of hemangioma because, as we've indicated, it's immediately subepidermal, and it's entirely very thin-walled vessels without any large feeder vessels. So this has been also given the term of angiokeratoma, because not infrequently these will be slightly papillary. They'll look a little bit keratinized in some areas, as you see here. This is a very characteristic lesion that is located most frequently on the scrotum or on the vulva. And in some situations with other symptoms, it may also be associated with some internal anomalies, such as can be seen in Fabry's disease, patients who may develop other findings in the GI tract. Relatively unusual and no other particular clinical significance other than that because they're so superficial, these may occasionally be damaged and bleed and create a little bit of distress for the patient in that situation. So an angiokeratoma of the vulvar skin, not in this case associated with Fabry's disease, but something to keep in mind if there are other symptoms present. In fact, I remember one particular clinical pathological correlation, the old CPCs from the New England Journal when I was just beginning training, where this was one of the key findings. So it's amazing how things from your residency can come back to you decades later. All right, our next.
I have a question. So angiokeratoma, is it commonly seen in young or elderly patients?
The age, it can be quite variable. I would say adults, not children, but it can be across a broad age group.
Okay.
Yeah.
Okay, good to know. Thank you.
So our next case, also from the vulva, and one of my goals today was to show you a spectrum of disease in some of these instances, so you see more than just one example and get an idea. So this lesion, again, we're looking at skin with adnexal structures, and we see a little bit of accentuation of the epidermis and a little bit of pale blue inflammation or something around the epidermis. And so we'll begin to sort of look here at the center of this lesion. And as we come into higher magnification, we see that it's not this blue band in the dermis that's of concern, it's what's going on in the epidermis that should give us cause. This is a very classical pattern of disease that has been called the pagetoid pattern. Essentially, it is a dual population of cells in an epithelial compartment. So when I say that, we have the normal cells, the keratinocytes here, and then we have these other cells with variably clear to pale cytoplasm, some spacing, some nesting, and in several areas we would see upward migration of these cells above the dermal epidermal junction. So it's probably this process that is provoking this inflammatory reaction in the skin. And we'll just go along so you can see several of these areas. But these can be single cells and occasionally small groups of cells, usually at the dermal epidermal junction, sometimes above. And here's one where we form leave a small little nest. And you see here, one of the things that would arise in the differential would be melanoma. And so looking at this particular nest here, we even see a little bit of pigmentation here. And so that reminds us that melanomas can look like this. But of course, because there are melanocytes and melanosomes in this area, anything that damages this area can produce clumping or drop out of pigment into the epidermis. Here we see in the superficial dermis little bits of pigmentation here. And that again would make you more concerned about possibly melanoma in situ. The other consideration, in particular in the vulva, of course, is Paget's disease, extramammary Paget's disease, because of course this can also occur on the nipple, which is essentially an intraepidermal adenotype carcinoma in situ, essentially. Sometimes associated with an underlying tumor, but not always. So those two differentials, melanoma and adenocarcinoma, intraepithelial adenocarcinoma, form the crux of the differential diagnosis. Now, there is a third entity that can occasionally look a little bit like that, and that is where you get an actual little clonal type of squamous cell carcinoma that arises in the epidermis and has a distinct dimorphic population of the neoplastic cells and the keratinocytes nearby. Here we'll see here some of the evidence of these cells coming up into the granular layer. Here you see some apoptotic cells, and again, a few little ghosts in the stratum corneum. These would also be a part of this neoplastic process. So our immunohistochemical stain sequence that we would use in this situation would be something like CK7, SOX10, HMB45, or any other melanoma cytoplasmic marker, MART1, maybe S100, to identify the melanocytes. And then the CK7 would be usually positive in most of the adenocarcinomas of this type. We can also do hormone markers like ER, PR, or HER2, because those will often also be positive in these cells in a majority of cases, because these cells tend to represent usually a mammary type intraepithelial carcinoma. Now, one of the challenges surgically for this disease is evaluating the margins. And because this is an in situ disease, they don't like to do radical surgery, so they tend to excise what they can see. And with a diagnosis of Paget's disease of the skin, what they see clinically is typically insufficient to get a good healthy margin. And so I show you here the ink at our lateral margin, but as you can see right here in this area, we have smaller nests of the same process going on here. And so getting a liberal margin is imperative. Occasionally, these are difficult to evaluate microscopically. And so sometimes even the immunohistochemical stains may be helpful in identifying where your margin is positive. So let's just go back here to lower magnification. Whoops, excuse me. Of course, in the vulva, it's not always just what they can see, it's also the anatomy. And so as we look here at this other sort of the outer side where you have more hair follicles, here, it's more difficult to identify whether there's positivity here or not. But I think you can even see here, there are a few of these very funny looking cells out here, well beyond the probably clinically visible lesion. Because most of what they're seeing clinically is this this dermal reaction. That's what's going to cause it to look a little bit elevated and maybe a little bit inflamed. Whereas out here, there's really very minimal reaction, and they may feel they're perfectly safe. But you can probably see here that, we still have cells out here, and it's very difficult sometimes to begin to know where to draw the margin. So that's why sometimes I will use immunohistochemistry in helping to evaluate the margin for these Paget's disease cases. We'll go on to show the next slide, which is also Paget's disease. And this illustrates another pattern that we can see, which is marked hyperkeratosis. You can see here at low magnification, we have a very thick layer of hyperkeratotic cells. Now, in this situation, we can identify this upward migration of some of these cells maybe a little bit more easily. Here we see some up in the granular layer, and here's one in the actual cornified or the keratinized layer. So we can see that these cells, like melanoma cells, tend to have this upward migration that is very helpful in identifying them as malignant, because benign nevuses and so forth don't send their cells upwards into the epidermis and into the stratum corneum. Another feature is that the morphology of these cells in the epidermis can be somewhat variable. Sometimes they will just have pale pink cytoplasm, and you'll see nuclear atypia and so forth. Sometimes we may actually see signet ring cells forms, particularly if there's any mucinous component to the tumor. And so the morphology can actually look like intraepithelial signet ring cell carcinoma at times, as well as just the more typical solid types of carcinoma or poorly cohesive types of carcinoma. And the reaction, as you see in this case, just again, a little bit of inflammatory reaction in the dermis or submucosa area. This lesion was probably visible because of the hyperkeratosis rather than the inflammation that we saw on the other area. Now, we don't recommend using frozen sections to evaluate this lesion, the margins on this lesion, while for much the same reasons that we don't usually do frozen section margin evaluations on melanoma. It's extremely difficult, and the false negative rate would be tend to be high, because this pagetoid pattern is partly the factor or partly the result of the fixation artifacts and so forth, processing artifacts that we have come to recognize readily. I'm not saying it's impossible to do frozen section on a lesion like this, but for full evaluation of the margin, maybe a Mohs technique perhaps might be suitable, but I would not recommend using frozen section to evaluate the margins on this routinely.
So can you tell about the prognosis of this patient compared to those with invasive disease?
Yes, very good question. The prognosis for these patients is generally fairly good. They may have multiple recurrences. And if they go on long enough, they can eventually develop invasive disease. Because of the margin issue that we've talked about, I would say that the recurrence rate is probably close to 50%, at least in our practice. I would say about half the lesions we see are recurrent disease. And it's sometimes difficult to, as we've indicated, to localize where it's going to arise from. We don't usually worry as much about an underlying invasive carcinoma. Occasionally, transitional cell carcinomas will grow out onto the vulva and present as Paget's disease. Occasionally, Bartholin gland carcinomas or Skene gland carcinomas or other sweat gland tumors can present as Paget's type disease. But those are definitely a minority of cases. And in that situation, the underlying tumor. The same thing in the rectum. Rectal adenocarcinomas can occasionally present as perianal Paget's disease. We have seen, and I had a case just yesterday where the surgeon will actually do kind of a mapping set of biopsies to try to define the extent of disease pre-surgery if they're contemplating a more significant resection attempt. It does need to be controlled if it can be locally because of that eventual risk of invasive disease. And as far as I know, there are not suitable medical or radiotherapy treatments for this disorder. Although certainly not beyond consideration of attempts, because that does work sometimes in breast cancer, but I don't think it's particularly effective in the vulva. Okay, we'll go on to the next case here. Just again, a vulvar skin sample. And this, as you can see, is kind of multiple little rounded lobulated fragments. And these are kind of what you might think of as little papillae that have just been kind of snipped off. And this slide I share to raise the topic of condyloma and to point out that not everything that occurs with the papillary architecture in the vulva is truly a condyloma. That is truly something with a human papillomavirus of significance to identify it. So as we see at this magnification here, there's nice maturation of the keratinocytes. We have some prominence around the fibroepithelial cores. We have a little bit of increased basophilia down here, but as we go upwards in the epidermis, these cells mature nicely. The nuclei are fairly uniform, and we don't have really prominent coilocytosis or perinuclear vacuolization that we associated with viral cytopathic changes. We can look at each of these papillae and see a fairly similar factor. And so with that distinction, I would resist calling this a vulvar intraepithelial neoplasia grade 1 or a condyloma, which I think are essentially equivalent terms in most situations these days. But I would prefer that we just call this a fibroepithelial polyp or a squamous papilloma because it does not have any of that viral cytopathic change. So these lesions can more commonly seen elsewhere in the skin, little squamous papillomas, but they can occur in the oral mucosa. They can occur on the skin, in the neck, sort of little acrocordon type lesions, as well as in the vulva. That's kind of all I wanted to talk about with that, just to make the distinction between VIN1 and condyloma and these fibroepithelial polyps. So let's go on to another cutaneous lesion, fairly specific to the vulva, although it has a lot of overlap again with breast, because obviously the vulva is part of the milk line. So here's a nice rounded lobulated tumor, and at low magnification we can see there's some very pink areas, there's some slight cystic areas, and there's a number of kind of slit-like spaces associated with this lesion. So as we come into higher magnification, we can see that it's mostly epithelium. And as we look at this a little bit more carefully, I think we'll see very readily that there's kind of a dual layer to much of this. We see these cells with sort of apical snouting and then some basal layers underneath them. So there's features that suggest there's a dual cell population here. Some of these, we see this nice apical snouting of these little blue projections of cytoplasm into the lumen, their underlying nuclei, and then some basal nuclei, myoepithelial type cells underlying those. So that's the fundamental features of a benign lesion with a sort of a dual cell population in these slit-like ducts and so forth. Let's look at some of these other areas here as well, however. And here we see a slightly different cytoplasmic or cytologic appearance, a little vacuolization and a much pinker cytoplasm with still a little bit of apical snouting on some of the cells, but fairly uniform rounded nuclei with a single prominent nucleolus. These look very much like apocrine cells. And here we can see some of the sort of cytoplasmic vacuolization that might also go along with that. This lesion with the sort of pure population like this, we would just call this a hydradenoma papilliferum. And that's a lesion that's commonly seen in the vulva. I did a short video on that topic just a few weeks ago. But this illustrates that they can also show areas of apocrine type metaplasia. And in fact, sometimes you can even see fibroadenomatous type changes in these lesions. All of this underscores that this is very similar to some similar tumors that are seen in the breast. Intraductal papillomas at times can have these features. Apocrine metaplasia, of course, can be seen in the breast. And this is a benign papillary neoplasm that probably originates in ectopic or extramammary breast type tissue, and can have these varying morphologies. I think the correct diagnosis for this would be hydradenoma papilliferum, perhaps with a little additional comment that areas of apocrine metaplasia are present. This lesion behaves entirely benignly. As you can see, we can excise with close margins and expect there'll be no recurrence. If it's incompletely excised, it's still probably okay, but might recur or create a few other problems in that regard. All right, so going on to our next case, again, skin from the vulvar region. Just to point out that skin diseases in the vulva may or may not be specifically neoplastic. This was, again, a slight papule, as we can see, sort of a raised area and an epithelial proliferation. Here it seems to be centered around a little follicle type structure. But as we come to higher magnification, I think you'll recognize that this is not a wart, which would be probably something that it might be confused with because of this sort of hyperkeratotic component, but in fact has these nice characteristic eosinophilic cytoplasmic inclusions, which are characteristic of molluscum contagiosum. So this is a quasi-infectious transmissible disease, a viral type disorder that creates these very characteristic cytoplasmic inclusions and presents as small reddish papules. This is not particularly a sexually transmitted viral disease. It may be other forms of close contact. It tends to be a little bit more frequent in children, but can occur at really any age group, and has this very characteristic appearance. Now, this can be a little bit variable, and that's why I've included 2 slides in the sequence to sort of highlight that depending on staining characteristics in your laboratory, they may be somewhat pink or they may be slightly bluer. As you can see here, they're a little bit more purplish color rather than the more reddish color in our previous case. And the association with a little bit of hypergranulosis is also characteristic of this lesion. So you see there's the inclusions, but then we also get very prominent keratohyalin granules associated with this as they mature and are being expelled. And that, I think, perhaps is an indication that there are circumstances. This is not a surgical disease necessarily. It can occasionally resolve spontaneously as essentially the body responds by proliferating and getting the infected cells outside the body and sort of expelling them that way. But this is, of course, the stage at which it would be infectious to other individuals when these virally infected cells are present and these inclusions are being extruded onto the skin surface. So 2 examples of molluscum contagiosum. Not a difficult diagnosis, but something that can occur in the genital regions as well as elsewhere. So we'll go on to another case, again from the vulva. This is obviously involving the skin and subcutaneous tissues. It's not clear whether it arose in the skin, but there is a little bit of cutaneous tissue remaining here. But it seems to be centered in the deep dermis, and it has this infiltrating, fibrosing pattern, which we can see at low magnification. And as we come in, we see these anastomosing cords of cells with small microcystic spaces, a lot of sort of reactive appearing tissue around that, sort of desmoplastic fibrosing pattern. And as we look at this particular case, these cells have a small cell appearance with these small microglandular spaces, and clearly malignant appearing nuclear features, a high NC ratio, clumped chromatin with the micronucleoli in these patterns. So this is obviously a malignant neoplasm, a carcinoma. And then the question is kind of what type of tumor? Well, there's a couple of clues. One is this pattern of microcystic spaces and occasionally little eosinophilic tubular type of structures here should suggest similar tumors that arise in the salivary glands. And occasionally in other locations, occasionally in the breast, occasionally in the lung. This is a lesion that is somewhat reminiscent of adenoid cystic carcinomas that, as we've indicated, occur usually in the salivary glands and so forth. They can occur, however, in the vulva, where whether they arise from the mammary / apocrine tissues is not clear, but they occur here as they do in other locations. And here's another component of this tumor where we see these small microglandular pattern of this lesion. Now, these tumors do have a propensity for perineural invasion, whether in the vulva or in other locations. And so we certainly want to look around to see if we're going to see that feature here. I don't recall on preview if I saw that. Did any of you who previewed that see perineural invasion with this case? Certainly there's a spread into the deeper soft tissues. Now, it would be useful in this circumstance to think about what might the differential include. Any adenocarcinoma primary in the vulva is probably more frequently going to be metastatic than primary. But primary mammary type tumors could certainly be considered. Skene's gland adenocarcinomas, very uncommon, but can be considered. And then these other type of tumors that we've discussed from Bartholin's gland or other locations can also be considered. In the case of adenoid cystic carcinoma, these tumors in the vulva will stain with the same markers that we would see elsewhere. That is, they would have some epithelial and some myoepithelial markers. And quite helpfully, they are also usually positive with CD117, which I think in unusual location like this, a carcinoma positive for that tumor, for that marker would be highly likely to be an adenoid cystic carcinoma. Okay, well, not to be ignored, of course, are the stromal neoplasms. And so here again, we see cutaneous tissue on the surface and an underlying neoplasm with a more mesenchymal appearance, a more solid pattern. And we would think at low magnification, what might this be? Well, you always want to remember the possibility that things that look like scarring, spindle-shaped tumors, melanoma, desmoplastic melanoma needs to be considered. Other neoplasms that can occur here, of course, phylloides tumors, sarcomatous tumors due to other components. And this is illustrative of one of those. This has a very pink cytoplasmic and fascicular pattern. As we look around, it's not difficult to find mitotic figures. Here's one here, another one here. So this is a very mitotically active tumor. And it has this kind of wavy cytoplasm that really nicely suggests Lyomyosarcoma, or at least a proliferative pattern. So is this a Lyomyosarcoma, or is it a other smooth muscle tumor with mitotic activity? So in general, in the GYN tract, there are three features that we look for defining a Lyomyosarcoma. One is necrosis, which we do not see here. Another is mitotic activity, which we've readily identified. A third is cytologic atypia. And while this is somewhat cellular, there's not a high degree of atypia here. So do we just have one of our three guideline factors? And I think that's true. We only have the one of those three. But there's a fourth factor that I think comes into play and can be very helpful in a situation like this. And that is, what is the pattern at the margins? In this situation, we have a very infiltrative margin. Here we can see the normal dermal collagen and infiltration by this spindle cell neoplasm in between the dermal collagen. That is malignant behavior. And so with the presence of an infiltrative margin and increased mitotic activity, we should have no difficulty classifying this as a Lyomyosarcoma, rather than just saying it's a smooth muscle tumor of uncertain malignant potential or something of that sort, where we might as we say, waffle a little bit between benign and malignant in other circumstances. Now, the other feature that's helpful here is this cuff of lymphocytes here. That is not infrequently seen in these neoplasms as a part of the response to the tumor, and can be fairly helpful, I think, in the cutaneous neoplasms. There are other lesions where that can be missed or not seen, but in this case, it's a somewhat helpful factor as well, indicating that the body is responding to this neoplasm as a threat type of lesion. Now, whether this will also play out to be something where to indicate utility of immune checkpoint inhibitors or not, that's yet to be seen. But this is an unusual example of leiomyosarcoma, in this case occurring in the vulva. Now, this patient also had a malignant smooth muscle tumor in the uterus. And so while this doesn't necessarily look like the usual metastatic tumor, that possibility would be most likely in a patient with another primary smooth muscle sarcoma. Okay, let's go a little bit further up the tract here, and I have some tissue samples here taken from the vagina. And I think this is a patient who had a history of cervical intraepithelial neoplasia and had a hysterectomy, and then presented with some abnormalities on follow-up exam in the vaginal mucosa. And this illustrates the fact that HPV disease is not restricted to the vulva or cervix, although those are certainly the most frequently encountered sites, but vaginal mucosa can also be affected. And here we see a nice full thickness or nearly full thickness lesion with a little bit of hyperkeratosis, variability of the size and shape of the nuclei in the epidermal component, some expansion or thickening of that component, and at higher magnification, some significant nuclear atypia. We see some occasional mitotic figures in here as well. Let's see if we can find a good one. I know last night when I was looking, there were some upper level mitotic figures. Probably that's one there. So this would certainly qualify as a high-grade squamous intraepithelial lesion. Now, I still grew up, obviously, with mild, moderate, and severe dysplasias and CIN 1, 2, and 3, and so forth. So probably this would fit for me in a moderate dysplasia or a CIN 2 because you have some degree of maturation at the surface. But as we look elsewhere a little further in this lesion, we might even begin to wonder if this is a low-grade lesion. So for example, if we had taken our biopsy, say here, we might have been inclined to just call this a vaginal intraepithelial neoplasia grade 1 because we just have a nice maturation and a little bit of coilocytotic change, and most of the proliferative activity is here at the base. So what do we do with the final diagnosis of an excision like this? Well, while in many cases it's not a situation where it progresses from CIN 1 to CIN 2 to CIN 3, there can be variability in terms of the morphology. And so we usually make our diagnosis based on the highest grade changes that we see. But we recognize that there is a risk if we have diagnosed a lower grade lesion that on resection there will be other areas of high grade change. We see this all the time in cone biopsies. We see it in vulvar disease as well. And whether it's due to infection with multiple different papillomaviruses, or whether it's due to variability in the progression is uncertain. One thing I will comment on is that if we see atypical mitotic figures, that is usually always associated with a high-grade lesion. So if you see, even in the base, even at the basal layer, if you see a tripolar mitotic figure or a ring mitosis or something like that, you can fairly confidently call that a high-grade lesion. Now, the other thing to see here is to just notice that there's a little suggestion of a little bit of sort of pagetoid upward spread here. You know, you see these paler cells up high in the epidermis or in the stratum corneum almost. And you might think of, you know, Paget's disease like we had seen earlier. And that's, again, underscores the fact that sometimes there can be clonal squamous cells that will have this pagetoid pattern as well. So squamous lesions are not a highly challenging lesion in most cases, but I did want to cover a few of those teaching points. The variability, the grading, and the fact that vaginal as well as cervical and vulvar lesions can be derived from human papillomavirus. Of course, this underscores the importance of vaccination to prevent as much of this disease as possible. We have very effective vaccines. They're fairly costly, but certainly much less costly than dealing with diseases like this. Okay, we'll go up to the cervix here with our next case. And I show this case for a couple of reasons. One, to illustrate a challenging differential, and two, to sort of illustrate the importance of not necessarily always bowing to what somebody else says, I guess you would say. So this is not one of my cases. This is a slide that was in the Teaching DAPA series. It's obviously cervix here, and we'll just take a look at some of the features here. The squamous epithelium is not where the action is. The concern here was with the endocervical component. And here we see nice lobulated endocervical glands with a little bit of surrounding inflammation. That's not atypical. We don't see much on the surface. There's again, we see nice mucin in the cytoplasm, but some of the surface has been denuded. As we look at these cells, we see a lot of abundant mucinous cytoplasm, basal nuclei, fairly widely spread in most areas. So as I look at this, I would say this looks most like benign endocervical glands in this area. So that's that fragment. I've classified that as benign. This fragment over here has a somewhat different appearance. As you can see, it gets a little bit villous. There's a little bit of sort of villous papillarity to it here. As we look at these areas, we can see, again, there's abundant mucinous cytoplasm. The nuclei are all basal, but they're a little bit crowded, and they're a little bit hyperchromatic, I would say, these basal nuclei. Now, this is not the appearance of the usual endocervical adenocarcinoma, where we would see stratification of the nuclei, karyorectic debris, and so forth. This case was submitted as a gastric type adenocarcinoma, which is a non-HPV type endocervical adenocarcinoma. And classically, that lesion was called minimal deviation adenocarcinoma, meaning that it was very minimally different from normal endocervical glands. And so we might say, well, is this an in situ version of gastric type adenocarcinoma? Well, in making that diagnosis, there are really only two things that can help you. One is the identification of mitotic figures, and the other would be a very mild degree of nuclear atypia. So I hunted and hunted on this slide to look for mitotic activity, and I found one. So here's the mitotic figure that I identified in that first area. It's not the usual, it's not a very convincing mitosis, but it's about as close as I could come. So I would say in looking at this slide that I can't verify that the submitted diagnosis is in fact the diagnosis. The cases of minimal deviation adenocarcinoma that I have seen have had an invasive component, which I do not think we have here. But we don't have other reliable markers to identify this de novo. This would be P16 negative. Conceivably, some of the muck stains could be seen in this lesion that would identify it as having a gastric phenotype. And so that might be helpful in looking at that, whether it's a MUC5AC, I believe, that's positive, or others that are positive. So the features here to raise suspicion are the slightly papillary architecture, the nuclear hyperchromasia, the rare mitotic figure, but beyond that, I don't think there's much here to help you with that. Now, these gastric type adenocarcinomas are usually older adult women rather than the 40-ish age group, which is when kind of the usual HPV-driven tumors tend to arise. So to contrast that, I have here a nice example of a usual type endocervical adenocarcinoma, which will illustrate both the cytomorphology that we usually see here. And in this situation, I think you can identify that these nuclei are somewhat stratified, they're crowded. There are areas where you see suprabasilar mitotic figures. And when I say that, in the endocervical adenocarcinomas, the mitotic activity tends to happen up near the lumen. So to divide, the nucleus moves up towards the lumen and there divides, and then goes back down a little bit more towards the base. Additionally, in these lesions, you'll see karyorectic debris very characteristically. Now, one of the, excuse me, I didn't bring any water this morning. One of the lesions, or one of the features that is difficult with endocervical adenocarcinoma of the usual type is defining invasion. So this lesion is somewhat exophytic. Here's the squamocolumnar junction. And here we have some benign endocervical glands. And here we have a slightly nodular area that's at about the same level as these endocervical glands. This nest of abnormal tissue is slightly deeper but still has a somewhat nodular appearance with some surrounding inflammatory changes. There are three patterns of invasion in endocervical adenocarcinoma. There is what's called the pattern A, which has essentially follows a very bland pattern like this, where it looks like it's just extending into pre-existing endocervical glands. And there's no inflammatory response. There's a pattern C, which is a very inflammatory single gland pattern. And here we can see some benign endocervical glands over here. So in this case, it's very difficult to define invasion because this could still be pattern A invasion, or it could be in situ disease that has extended into pre-existing endocervical glands and just become a little bit more complicated. The clues are the kind of lobulated architecture here to favor it still being in situ. Well, the difficulty for this, of course, with biopsies is that defining invasion on a biopsy can be extremely difficult. And even on cone biopsies, it may be difficult to define the depth or extent or even presence of invasive disease, which makes it such that not infrequently, if they've done a cone biopsy and then they do a simple hysterectomy, they may run into problems with discovering occult invasive endocervical adenocarcinoma, and therefore they'll have done the wrong surgical procedure. Because if you have a middle or deeper third in invasive endocervical adenocarcinoma, you really need to do a radical hysterectomy in these patients. So understanding that distinction in terms of surgical management, understanding the pitfalls with this disease and the different invasive patterns is very important to proper patient management. Let's see, I think I have one more example here. Because again, endocervical adenocarcinomas can be quite challenging. And this is obviously a cone biopsy. And we'll focus here on this lower fragment first. As you can see here, we have widely spaced normal endocervical glands here. And then we have an inflammatory reaction here. And as we'll see, we also have some cytologic differences. So here's fairly normal endocervical glands, maybe a little bit of columnar hyperplasia. And then right next to it here, and different morphology. And here we can see the classic features, some karyorectic debris, and here are these mitoses up near the lumen. Again, there'll also be some inflammation here. Now, because these glands are of the size they are and the location at a depth comparable to these other benign endocervical glands, I would presume that this is still in situ disease here, here. Same thing here. And you can sometimes see partially involved glands, like maybe this is a partially involved gland. On the surface, again, we see why these cells, look different when they're seen on Pap test. Now up here we have, let's see, it's maybe been the other fragment. Let's look at this other fragment. Now, in this case, I think there's evidence here near the surface of very superficial invasion. So here we have a benign gland here, and right next to it in an abnormal configuration is this malignant gland. And I don't think this is a pattern that you could see with either partial replacement of the gland or involvement of benign glands. So I think this probably represents very superficial early invasion in this lesion. Now, having said that, very focal superficial invasion has an excellent prognosis and would not require radical hysterectomy, of course. This, I think, here is still in situ involvement of a pre-existing gland. So maybe you could make the case, well, that's sort of not all that different than what you're seeing here. But you could make the assertion that it's either highly suspicious for or may represent very early invasive disease. So there's some discussion on some of the ins and outs of endocervical adenocarcinoma. I see that we have run out of time, and I did not get to a couple of the most interesting cases that we were going to do today. So I am going to stop here, and I will just tell you that I will present a video discussion of those two other very interesting entities later, so you can watch the YouTube channel for presentation on those two cases at a later point. But I'll stop here and entertain any questions that anybody has. I don't see any in the chat. Does anyone else have any questions that they would like to bring up at this point? Well, that's looks like things are silent in the chat and silent in the voice. I want to thank you all for joining me. We appreciate these opportunities to do this. We're excited for any interaction and so forth because we don't get to talk to you very directly. So I hope that you won't feel bashful in terms of bringing up questions.
Yeah, thank you. So much. Very nice and interesting cases. Very educational.
Thank you, Hui. Thank you, Sahar, Zui. It's a pleasure to have you.
Okay, see you next time.
See you next time.
Have a good day.
Have a good day.